Hey Facebook, it's Dr. Jason Radicke. Thank you very much for joining me tonight for the Doc Talk with Dr. Rad. Dr. Rad is a short version of Dr. Radicke, and it seemed much cooler than Radicke because nobody could ever really pronounce that. So thanks for joining me. A couple of things, let's get out of the way. One, I'm a real person with a real life. I have dogs. I have 3 monsters that we call children and a beautiful wife. So if they interrupt this, you'll meet them all. If you hear dogs barking or children laughing and playing, it's because I'm doing it from my living room. Secondly, who am I and why are you talking to me? Or why am I talking to you? The reason is because Facebook is pretty cool. And I found, I think, a medium where I can reach a bunch of people. If you actually think about it, most doctors, I think, went into this because they wanted to help people. I actually love people. I enjoy people. It's a social thing for me too. And I love my job. I like working with my hands. I like using my brain, what little bit I got left. And if Facebook allows me to talk to 10 people, 10,000 people at one time, I think disseminating information that way is actually pretty cool. I've been reluctant to do this for a very long time, but I've had some friends talk me into it. So here we go, first shot. All right, who are you talking to? Dr. Rad, or Dr. Radicke. I am knocking on 43, which means I am not young, but I am not old. I'm in the middle of my career, which is kind of important. We call that wisdom in surgery. We have a name for it. It's called a WOS, a wise old surgeon. That means you've seen enough to know better, but you haven't seen it at all. 2, I spent about 16 years in higher education to be sitting here talking to you tonight. That doesn't mean I know everything, but it means I know enough, enough to have an opinion, and I think that's important. We call that an educated opinion. So, my background. I grew up in a hole in the wall in West Virginia, and I'm very proud of that. If we're related, if not, we could be. Further, I have a brother and a sister and 2 loving parents. My mom is a nurse she'll tell you 49 years. I'm going to tell you it's 53 years, and she's still a nurse. My father plays the guitar and sings for a living, and he's pretty good. Even though he's white-haired, he's still got a great voice and loves to continue performing. What does that mean? That means I grew up in a family who was just extremely supportive. Right brains, left brains, all the good stuff there. I went to Clemson University. If you really went to Clemson, it's pronounced with a P, and everybody will know what I'm talking about. So Clemson was wonderful for me. I did a undergraduate in biochemistry, and I went on to do a master's PhD track in immunology and molecular medicine. Then I didn't know what I wanted to do with my life. So as I finished my master's, I actually figured out I like people. I like medicine. So I went into MUSC, which is the Medical University of South Carolina. There, I thought I was going to be a family practice doc. In fact, I would have sworn to you I was going to be a family practice doc. I love diseases, I love diabetes, hypertension, all these things. I like the medical background of these things. And then I did a surgery rotation, and anybody who knows me knows that story is long, so I won't bore you with that. But the long and short of it is, I thought I would hate it. I ended up loving it. And the truth is, most of it was instant gratification. It was, if you came in with a bad gallbladder or an appendix, I got to fix you, and that was a good thing. In the sense that you came in, you had a problem, I took you to surgery, you got better. And I liked that, and obviously the patients liked that. The problem I had with the medical aspect of things from a family practice medicine was I felt like you come in with hypertension, I give you a medication. Your hypertension is not fixed, I give you another medication. I ask you to lose weight, I give you a medication for cholesterol. And it just feels like it spins like that. Surgery felt like more of a fix, and I liked working with my hands. So it worked out pretty well. So off to 5 years of surgical residency at Union Memorial, where we did some stints at Hopkins and shock trauma and Maryland pediatrics. Oh, thank you, Ginger. Love it. 90 pounds today. That's awesome. Thanks, guys, for feeding in too. Just to kind of halt on the story. The way this works, I think, is that I'm watching this screen. You make comments. I comment back on that. And if you have any questions, please, please, please send them in. I'm going to try to answer them as many as I can. And if this goes the whole hour, awesome. If it goes 6 hours, not awesome. And if it goes 20 minutes before I dive, really not awesome. So, furthermore, back to the story. 5 years of residency taught me a couple things. One, I loved surgery as much as I thought I would. Two, it was tough. One of the questions someone asked is, do I love being a surgeon and how hard is it? It's hard. You have to sacrifice a lot, and that's okay. Most people understand that. A lot of people sacrifice, so doesn't make me special. But other people in medicine understand that sometimes your family's going to take a back seat to your career. There's many times, for instance, last night, I took 6 phone calls in the middle of the night, and that meant my wife wakes up every single time the phone rings as well. What can you do about that? Well, when you come home, you become super dad and super husband and super brother and son and all the other aspects and modalities of your life, and that's the best you can do. So my family understands, they're proud of me, and they're proud of my choices. So long story short, I finished residency and I realized I still loved medical diseases. And one of the things that I thought I could do is go into a field where I can not only do surgery and help people, but also do something that involves a lot of the medical diseases. So I went and did a fellowship, actually I did 2 fellowships, one in minimally invasive and one in bariatrics, which meant that I could still practice surgery doing breast cancers, colon cancers, hernias, gallbladders, all those great things, but also I could specialize in everything that you could do with big incisions, I like to do through small incisions. People will recover faster, it's just beneficial to the patients, and I thought it was a great idea. Also, the bariatrics thing is a way that I can not only get instant gratification, you're helping people, but they get instantly better, right? Their diabetes, hypertension, cholesterol, sleep apnea, these things melt away unbelievably quickly. And I wasn't just giving pills and telling them, please lose weight, please exercise, and let's get you better. You actually did something that fixed it with an excellent statistics. So, and I think it just made me a better surgeon all around. So that's why I went into bariatrics, and I've never regretted it, not for a second. It's difficult, it's tough surgery. It's very rewarding though. And then, if I take out your appendix, 2 years later somebody's going to say, wow, you had appendicitis, who did that? And you're going to say, some really nice doctor in Sebastian, I can't remember his name, but he was really cool and he did a great job. But in bariatrics, I follow you for 5 years, 10 years, maybe more. We go through ups and downs together. It's a journey, and it's awesome. So hopefully in 30 years, somebody remembers my name. All right, that's my background. Let's get to some questions. So one of the questions is, what kind of surgeon are you? I kind of touched on that, but let's go back at it. Although I did a fellowship in bariatrics and minimally invasive, I also do most other kinds of surgery that a general surgeon does. Things I'm very, very passionate about are breast cancer. That's a really big deal to me. Many of you know, and it is sad, but and he's greatly missed, but my uncle just passed away this last year of stage 4 breast cancer. And you may be asking yourself, did I say uncle? And I did. My family has the BRCA2 gene, which is kind of a big deal. It is a big deal in the sense that you have a much higher propensity for getting a breast cancer. So I'm extremely passionate about that. My uncle actually fought for, I think, 11, almost 12 years. He got to see his son get married, and he got to do a lot more things. So I'm really proud of him for his fight. But he also was the first one to show my family that we have that genetic disorder. Since then, my cousin, his son, my twin brother, and my father have all have the gene, and my twin brother actually just had a bilateral mastectomy last year, and I'm very proud of him. He went through that to prevent cancer so he could continue to be a father and a husband to his family. So it strikes very dear to my heart, and I think it's important. Otherwise, I do hernias and gallbladders and appendix and you name it. Any general surgeon, we do colon cancer, perforations, all that stuff. And then, of course, a large part of my business is bariatrics because I love it and I love weight loss. I do medical weight loss and surgical weight loss, and I think they're very, very important. The statistics would tell you that medical weight loss is tough. That doesn't mean it's impossible. It's just tough. So I love answering questions about that stuff too. I'm really into it. Let's see. Here's another question. Should bariatric surgery be done as a last option? If so, why not? And that's from Stephanie. Stephanie, that is a darn good question. Should bariatric surgery be a last resort? Unfortunately, I think that's how most people treat it. That is not how I think bariatric surgeons would like it treated. Meaning, you are 40, and let's say that you weigh 310 pounds, and you go to the doctor, and all of a sudden he tells you, oh, you're hypertensive. We need to start you on a medication for that. By the way, your cholesterol's up, and I really think you have the beginnings of sleep apnea. Okay, so you try a diet, right? One of the fad diets or Weight Watchers or something good, and that's wonderful, but you lose 20 pounds. Awesome. Well, over the next 5 years, you gain the 20 back plus another 30, so now you're 340. Well, you go back to the doctor, it's been a few years now, and oh, you need another blood pressure medication because it's worse and your cholesterol's bad and you definitely got sleep apnea, and now we're concerned that you have fatty liver disease, okay? Well, you know, surgery, I don't know, that surgery thing, that's kind of scary, and that's a big deal, and oh, it's surgery, it's permanent, you sure you want that? And so you postpone another 5 years. So now you definitely got fatty liver disease, you're on 2 medications, your kidneys are hurting because of your hypertension, now you have diabetes, sleep apnea, and now you're 50, 1, 2, 3, 60, pick an age. The point being is, with statistics saying that medical weight loss, and look this up, by the way, disclaimer, if I say something that doesn't sit well with you or you don't think is true, don't take my word for it. Go look it up. Dr. Google didn't really go to med school. However, there's some great information out there. Pick a website that's good. Hopkins has a great website. Mayo has a great website. People like this. Go to these websites and look this information up. I think that's great. I wouldn't just do a Google search because you may get a lot of different answers. Having said that, statistically speaking, your chances of losing weight from a medical diet and keeping it off for 5 years is only about 2%. That is a real disappointment. You know, your chances of losing weight after surgery and keeping it off are unbelievably high. You know, bypassers regain, in theory, 10% of their weight in 10 years. Sleeves regain 20 to 30% of their weight in 10 years. But if you've lost 70 and 80% of your excess weight, well, that's nothing to regain. The problem is, when were you a better surgical candidate? When you were 40 and you had hypertension on 1 medication, cholesterol problems, and the beginnings of sleep apnea? And when would you rather get those good years back? When you're 55 and 60 and have the surgery, lose the weight, and then you're doing good? Or would you rather do it younger and get the benefits earlier and then keep it off? That's a tough question to answer. In my opinion, I think the younger and the less medical problems you have, if it's a genetic thing and it's in your family and you know you'll be struggling with this and you struggled with this most of your life, then I say get to work. Let's get to this early. So that's a great question. Let me see if there's any live questions right now. One of them was, do I remove loose skin after weight loss surgery? That is a great question. My partner and I started thinking about doing that. I've certainly done it a few times. I have done it actually many times for people who have, am I really 48? I am not 48. That is a good live question. I am not 48. And for those who are asking, by the way, I have been asking my wife to buy a boat. I'm struggling. I know many of you men out there have done that too. I'm with you. You know who you are. Okay, off track. Back to this. I have removed plenty of skin. In fact, I will post some pictures of that if you guys want to see it. And it's a great surgery. However, I will say this about every surgery out there. 2 things actually. One, and this is just a sidebar, second opinions. Never be afraid to get a second opinion. And if your doctor doesn't like that because of his or her ego, that's their problem. It should not offend someone to go get a second opinion. And it should make you feel better that you did that because you have 2 opinions and hopefully they coincide. But everybody's got an opinion, even doctors, right? Secondly, the other thing I would tell you all the time is go to somebody who does what you want done every day. Meaning, let's take bariatric surgery because it's what I do. If you go to a surgeon who does 10 a year, that is concerning to me, right? Maybe they're a great surgeon. Maybe they'll do a good job. But you want to go to somebody who does 100, 200, 400 a year because that is what they do. So if you say to me, Dr. Rad, do you remove loose skin after surgery? Yes, I can. And I've done it when there was kind of an urgency or emergency, like you had so much skin that it was losing its blood supply and stuff like that. But for the most part, you should go to a plastic surgeon. Good news is we have some hookups with some plastic surgeons who give our patients a discount because we send them a lot of business. And obviously you don't want to take the kickback, so you pass that on to the patient. And I think it's a great thing. I think it's a really great thing. I will also give you a hint. If you get more than one thing done, let's say your arms, your neck, your breasts, and your belly, or pick a couple of these, you get discounts. So if you can do a twofer or a threefer, it gets cheaper as you do more. I know one of the next questions is insurance going to pay for that? Unfortunately, usually not, right? They consider that cosmetic. However, there are some opportunities to get insurance to pay for that. Some of the criteria you got to meet, and what you want to do is as you go to your doctors, get them to, let's say, diagnose you with these things, or at least place it into their note. Things like, you have more than 5 inches of hangover of skin. This is referring to your pannus and your belly. 2, it inhibits your activity. 3, it can be painful. The skin stretches, it hurts. 4, you can have what we call venous congestion, just bad blood flow to the most distal part of the pannus. 5, you have candida infections, some rashes and stuff under the skin because the skin folds are so significant. These things will help you get it covered. And if you have some of these things, and honestly, many people do, insurance will consider paying for that. So just remember that. It's a kind of a background trick to get this potentially paid for. All right. What are my options if I've had a sleeve gastrectomy and I've gained weight back? That is a great question. Let's see. That one comes from Ron. So Ron, here's how this works. A sleeve gastrectomy is a great surgery, right? You remove somewhere around 80-85% of the stomach, and then you will lose somewhere around 60 to 70% of your excess weight, typically within the first year. So that's an awesome surgery. The problem is you can still eat whatever you want, right? And your stomach will stretch. So that is another question that I'll answer right now. Yes, your stomach can stretch a little bit. It's meant to stretch a little bit because I don't want you losing weight for the rest of your life. That doesn't make sense. You'll dwindle down to nothing, right? Your weight needs to stabilize. That comes from, one, getting off the diet a little bit, right? The farther you get from surgery, maybe a little less serious and committed you are to it, and that's okay. That's life. 2, your stomach can stretch a little bit. And by doing that, in theory, you can eat more, right? And so here's the deal. I tell my patients, by the end of 2 years, you and I could go to lunch, an hour lunch, right? Not the American lunch, the 20 minutes, shove food down your face, get back to work, because that's what we do. I'm talking about the European lunch, right? Where we go, we hang out, I ask you about, Aunt Betty and Uncle Jim Bob, and you ask me about work, and we're cool. And we take an hour. You should be able to eat a 6-inch sub, maybe a Diet Coke, and forgive me, Barbara, for saying Diet Coke. Hence, that's an appropriate meal to have stable weight and not gain weight. That's appropriate. Now, if you ask me right now, I can eat a 12-inch sub, the cookies, the potato chips, and the Coke. That's a problem, right? That's a significant problem. So what is the number one reason people regain weight after surgery? It's called maladaptive eating disorder. We go back to some bad habits, right? Instead of a 6-inch sub, it's 6 inches of Oreo cookies and emotional eating. And that's a problem. So you get back on the wagon. The tool is always there. That's important. The tool is always there. Now, if you can eat a lot more than a 6-inch sub, that's a problem, right? The surgery's not doing what it was supposed to do. So there's a couple ways to check that out, right? You can do a CT scan, you can do an endoscopy and look down and say, how big is my stomach, right? Because we removed 80 to 85% of it. So in theory, it should not be that big. but it will stretch over time, so you go look at that. Now, what are your options? Well, hardcore diet. Is there such a thing as shrinking your sleeve? Well, yeah. Anybody who goes on a 2 or 3 day fast, if you try to eat again, you're not going to be able to eat nearly as much before you get full. So yeah, you can do that. Does it actually shrink your stomach? No, it does not. 2, you can do a revision. In my opinion, sleeving a sleeve is a very bad idea unless somebody gave you a huge sleeve, and that's not a good surgery. That's not a good surgery. You can convert a sleeve to a bypass, and I'm not going to say easy, but it's fairly easy as a really good option. And of course, there's another surgery called a duodenal switch, which I won't touch much on now. It's certainly not controversial, but usually it's reserved for people with high BMIs or severe diabetes who really need some help. So those are some options. Those are great options. If you feel like that's the case, call my office. Let's talk about it. Let's get it in. Let's do the EGD. Let's do the endoscopies. Let's do the CTs. And let's look at your stomach. Let's see what's going on. Or let's talk about your habits, things of that nature. All right, let's take another question. Melissa says, 2 years post-op, what should my macros look like right now without going to the gym? Okay, let's look at the second part of that question, Melissa. Without going to the gym. All right, let's talk about something real quick. I want to throw in a true statistic. The number one way to keep weight off after you've lost it, I don't care if it's a medical diet or surgery, is exercise. That has been proven and proven and proven. This is over 250 years of literature. Not all of us love to exercise. I'm exhausted when I get home. I get it. I swear to you, I understand. And I want to be a dad, and I want to be a husband, and I want to be everything to everybody. There is a trick in finances called pay yourself first. And I like that idea. So I have a rule. I have to pay myself first. And if I don't take care of me, then I can't take care of my family, I can't take care of my job, I can't take care of my patients. So before I do anything in the morning, I either get up and exercise, or when I get home, I want to exercise. And if I don't do that, well, then I double it up the next day. So I don't like that. I have arthritis, my back hurts, my knees hurt. I get it. That is the number one way to keep your weight off. All right, having said that, let's go back to the question. 2 years post-op, what are my macros supposed to look like? So macros is a really good fad. I think it's legit. There are multiple schools of thought here. So this is for everybody. Weight loss patients, medical weight loss, dieters out there, everybody. There are multiple schools of thought. Some people believe in just macros, macros, macros. Some people believe that a calorie is a calorie is a calorie. And as long as you keep calories down here, that's it. Okay. How do I feel about this? This is a tough answer because I'm a biochemist, I'm an immunologist, I'm a surgeon, and I'm a medical doctor, all wrapped in one. I honestly feel like a calorie is a calorie. I mean, if you think about it, a calorie it's actually a joule, right? It's kilocalories, per gram. And we get that from food, right? So you would say, oh, okay, carbs and protein are somewhere between 3 and 4. Oh, fat burns at 9. Even alcohol gives you high energy. It's burned at 7, right? But the point is, if your body spends 2,000 calories a day just breathing and walking around, well, if you only eat 2,000 calories a day, well, then they even out. You don't gain, you don't lose. But if you want to lose, you throw in some exercise. You burn 300 extra calories that day. Well, there you go. You're going to ultimately lose weight, right? So calorie for calorie. Now, having said that, let's go backwards and say, oh, well, a calorie is a calorie, so I don't care if you eat fat or carbs or protein or beer. Okay, not all calories are created equal. What does that mean? Well, what do you think your body's going to look like if you spend 2,000 calories a day, you burn them, but you eat 2,000 calories of Twinkies, right? Well, you're not going to gain any weight, right? You're not going to lose any weight, but all you eat is Twinkies. I don't think your skin's going to love that. Your hair's not going to like that. The places where you actually gain weight and lose weight are not going to like that because the fat is deposited in different places. Now let's talk about if I switched up and I had high protein low carb, an Atkins-based keto diet. That's interesting. Well, you'll gain muscle, you'll lose mostly fat, and the fat distribution will be different as well. And then the last thing I'll touch on the macros is hormones. That is a tough question. All these books are coming out about that. There's newest medicine out there. It's called bioidenticals, and I love it. It's complicated, and I love it. But I am not the same man I was when I was 20, right? My testosterone's gone down. Central obesity is a constant fight for any guy above age 35. Women are well distributed, but when your estrogen starts dropping and you start going towards menopause, your calorie burning a day just tanks. It's a problem. Plus our weight distribution. It goes to our hips, it goes to our belly, it goes to our face. And these are complicated. Food is also hormone provoking, right? Estrogen, progesterone, and testosterone. So this is very important. These are hours and hours of conversation, and we can certainly get into this. I'll probably do a talk on that alone one day. But what should your macros look like? Even it up. I would say a higher protein, low carb, medium fat. Those are great diets. The two diets that I think work the best are a hardcore Atkins, right? High protein, low carb. When I say low carb, 50 to 70 grams of carbohydrates a day should keep you in ketosis, which is how you are burning that fat. The other diet that works equally as good, if you take out the dehydration aspect of the Atkins diet, is a low fat, moderate protein, moderate carbohydrate diet. That works just as good. I actually like that one better for long term. So when I do medical weight loss with my patients, we hit an Atkins diet hard. You lose great weight. We burn it. Then I convert you over to something that looks more like a low fat, moderate carb, moderate protein diet. And that's something you can maintain for life. Great question. All right, next question is Crystal. I keep seeing that there are different metabolic types and only certain food work for different types. Is that true? Oh my goodness. That is almost the question we just answered. I'm going to go ahead and bounce that one, but absolutely, there are different foods for different metabolic types. Everyone can tell you that I do Weight Watchers and it worked great. I was a vegetarian. That's the only thing that worked. I did a low carb diet. That worked. I will tell you that from a hormonal aspect, everyone is different. It's based on, are you a male or are you a female? Are you 20 or are you 55? Can you exercise or can you not, right? If you're 65 and you've had 2 hips and a knee replaced, it might be a little bit hard for you to go out and run the marathon. So that's a complicated answer, I know, but yes, that does matter. Karina, what do I need to do to get my insurance company to cover this? Ooh, that is a great question. That's a bariatric question. Unfortunately, not all insurances are created equal. I'll give you an interesting statistic. Why won't my insurance company cover this? It only makes sense. They're paying for my diabetes meds. They're paying for my sleep apnea, my cholesterol, my this, that, and another. All these things. And I end up in the hospital with, asthma attacks and sleep apnea associated issues and this heart attack. And ultimately, you think they're going to pay a lot more for your medical problems that are all going to dissolve, by the way, after weight loss surgery. Well, let me ask you another question for my finance junkies. How long do you think an insurance company is kept by one individual? Meaning, how long do you think you're going to have the same insurance company before it changes? Now, you may not change it. It may just be your employer, or you could change jobs, or maybe you're on your husband's or wife's insurance program. But the average person only has their insurance for 2 years, and then it changes. And the insurance companies know that, right? So why would they pay for a weight loss surgery that somebody else is going to get the benefits of? Now, it doesn't always work that way, obviously, but if you take a look at Medicare, Medicaid, they've been paying for this surgery for a long time, right? Because the government understands that once you're on Medicare, Medicaid, typically you're staying there for a long period of time. So they want to get the benefits. They want you healthier so that they can win in the long run. Makes sense. Many insurance companies are coming around Honestly, it's one of those things, if I could get every single person to call their congressman or congresswoman and beg them to start, implementing these things and asking private payers to, have insurance coverage for these, obviously it'd be a great thing. People are coming around. Obesityhelp.com. We have the Health Acts, the ASMBS, which is the American Society for Bariatric and Metabolic Surgery. These are huge entities and coalitions that are working towards pushing people to get their insurance to cover these things. More and more are doing it, and I think it's a great thing. There's obviously ways to do it outside of that, right? I honestly think that probably my company has one of the best self-pay prices out there, but it's still about $10,000, right, for a sleeve, and something like $12,000 for a bypass. That's a heavy price. Not everybody can come out of pocket for that, but ultimately, if you think about the money you save in the long run, it's worth it. But it's not easy to come up with that. So that's a great question. All right, guys, I need some live questions. Get them in there. I want to answer your questions live. Even my hecklers, bring it on. All right. This says, Callie. Callie has 3 questions. I'm going to see if I can throw them all together into one. What made me choose bariatrics? I already answered that. America is said to be the most obese country in the world. I believe mostly stemming from mental health and addiction. What do you think? Woo! She's setting a landmine down for me. I appreciate it. Thank you, Callie, for that. That's awesome. You're right. Obesity has many, many aspects. You cannot blame it on just one, right? So there is genetics. No question about it. No question about it. It is said that if you have one parent that is obese, you have a 45% chance of being obese as well. If you have 2 parents that are obese, you have something like an 88 to 92% chance of being obese yourself. Well, that's a pretty darn good statistic, right? I mean, so genetics definitely play a role. However, it's not just that. Okay, why America? Well, genetics are genetics, and we continue to breed within this country. However, we are the land of the plenty, right? And we have McDonald's, we have fast food restaurants, it's cheaper to eat junk, right? That plays into it, and that's a problem. Hormones. We've talked about this for years. There are hormones pumped into chicken, hormones pumped into beef, and we're eating those. So young ladies are maturing much, much faster. Kids are weighing much more earlier. They're growing to bigger heights, all these things associated with that. So from a standpoint of, is it one thing? No. There is also certainly mental health. We, in this country, in my opinion, we work too hard. Now that's the, pot calling the kettle black, but from a standpoint of we work too hard and we're too stressed, right? And what do? Well, we compensate with eating, and we don't eat well. We don't cook our meals. We don't, do what we used to do in the 40s, 50s, 60s, and even 70s, right? It became easier to just get the fast food, get the fast meal. And then if you're stressed, that's a problem. Other countries have said, let's look at Europe. Many countries in Europe mandate things like 15 weeks of vacation or time off in a year. You can forget that in this country. So that certainly attributes to it too. And yes, mental health problems in this country are far undercared for. And I think that that's a huge issue. That's a huge issue. Somebody asked me one time if I had one prescription that I could give out to everyone, what would it be? And I said, a counselor. I think everyone could use a third party, a person who is not jaded. Their job is to just listen and turn it back on you and reflect to you what you just said and make you think about it. That would be the number one prescription I would give for everybody. All right, we have a live question. Oh, I had a vasectomy and my wife still got Prego. What to do? That's interesting. That is also a landmine. Here's what I would do. Oh my gosh. If I'm red, forgive me. Here's how this goes. Certainly, vasectomies can fail. After a vasectomy, do yourself a favor. First thing after a vasectomy, wait a couple weeks, go back and make sure it worked. The only way you can do that is to actually check your sperm in an ejaculate. And if you look at it and they're still swimmers, you got a problem. All right, didn't work. Have it done again. Secondly, if you missed that, or you didn't go to get your boys checked afterwards, do yourself a favor. Go get it checked now. If you still have swimmers, it's probably your kid. If not, then you get it checked. John says DNA. Well, that's a yes. So, like I said, get it checked. If you have no sperm in your ejaculate, then there's a problem. But anyway, I'm glad I could step on that landmine, and thank you very much for making that doc talk with Dr. Rad about vasectomies. I love that. Speaking of which, I think I'm due for one. All right. Crystal, I have gained 50 pounds in the past 2 years and have tried diet and exercise. I only dropped 5 pounds and then I stopped. That's a good question. I've talked to my GYN and they've checked my A1C and thyroid, both normal. Are there other tests that I should have done that could indicate why weight gain is difficult for me and why that's happening? That's a really good question. Again, it depends on age, it depends on your exercise, your metabolism, what your hormonal milieu is, all these things. I would certainly say you check thyroid, that's great. You need to check estrogen, you need to check progesterone, you need to check follicular hormone, you need to check luteinizing hormone, you need to check all these various things, even your testosterone, to know if you're having a major deficit in one of these areas. After that, if there's no deficit, then you need to look at kind of what you're doing. Meaning, I have made people download, I don't care what app you download. For instance, there's calorie counters. There's multiple different calorie counters out there. They're all really good, but some of them you can actually enter your macros in, which is awesome. You're going to enter those, I mean stringently, because I have people who swear to me they eat 1,200 calories a day. I swear to you, I swear to you. Then they do their macros, and it's like, oops, I eat 3,800 calories in a day. By the way, here's a statistic, really neat article I read. Guess how many calories extra that a chef eats in a day, just because they're tasting food? And the answer is 3,800 extra calories. Hence, don't trust a skinny chef, because if they're tasting food, they're probably taking in extra calories, and that's a big deal. Oh, hi, Mom. Thanks. Hi, Mom. Hi. Yes, my mom. 53 years a nurse. Nonetheless, just by sneaking through the kitchen and picking up that one cookie, eating just a couple crackers, one drink, one soda, any of these things, that is literally adding calories. I will say another thing. Liquid calories are the worst because they're easy. They go down easy, they leave your stomach fast, and leave you hungry again. That is a problem. The only way you know you're full is the stretch receptors in your stomach. Your stomach literally has to be stretched. It sends the receptors up the vagus nerve that says, hey, I'm full now, and we stop. But if you eat food, and yes, protein does have a slower transit time, it sticks around your stomach longer, but food sticks around longer and keeps you full longer. Whereas liquid leaves faster and gets you hungry again. So, something to consider. All right. Natalie, is being a surgeon hard? That's a good question. I find myself repeating this to people more and more, especially to my children. If you love what you do, you'll never work another day in your life. I certainly didn't come up with that, but it has become more and more true in my life. I love what I do. It is very tough. It takes a lot, right? A lot of energy, a lot of time, a lot of brains, exhaustion, time away from my family, but I love it. Why do I love it? I think I just love people. I love helping people. I know that sounds cheesy, but it's true. I get a lot of benefit out of it, and I feel like I'm touching people's lives, and they touch mine. It is a wonderful, wonderful way to spend your career. So I enjoy that. All right, let's do a couple more questions, and then I think I'll leave you guys. So let's talk about breast surgery. Breast surgery. Okay. Why would somebody, my kids are trying to join us. We're going to get them out of here though. All right. First of all, what are the options if somebody has a breast cancer? That is a great question and a tough one to answer, but let's just do a superficial brief answer. Okay, one, if you have a breast cancer and you find out from either a biopsy or a mammogram or something of that nature that's very concerning, the first thing you'll likely do is get what's called a core needle biopsy. It's a biopsy that's done with a needle. It usually numb you up. It is usually fairly painless. Some people obviously can experience pain from that, but it's usually fairly painless. This was something that's just come out in the last, the generation, I'd say 10 to 20 years. By just a needle biopsy, you can tell what kind of cancer it is, if it's hormone receptor positive or not, and this is a huge deal. Back in the day, we used to have to actually just go to surgery to tell you what it is you had. We don't have to do that anymore. One of the big rules in surgery is don't let the skin stand between you and a diagnosis. That's really important. The Art of War, one of the things that came out of that book was know your enemy. Well, if you can know your enemy before you go to surgery, that's important. We call it stacking the deck. You stack the deck in your favor and your patient's favor. All right, so then you come to my office and we talk about your particular situation. Let's say you have a breast cancer. Well, the first thing we want to try to do is figure out which stage you are. It may require more imaging, or we just might be going to surgery. Now, the options are lumpectomy. That means we go through a small incision and just carve out the cancer with a good margin. We will test a couple of lymph nodes. We call that a sentinel lymph node dissection. We would just test a couple of lymph nodes. By doing that, we can tell you a couple things. One, we got good margins on your cancer. It's out. Two, your lymph nodes are positive or negative, most likely negative. So now you're cancer free and we know what your lymph nodes are. Now let's switch gears. A mastectomy. That is something everybody knows what that is. That's where you remove the entire breast. So by doing that, you know you got great margins and you're going to test the lymph nodes at the same time as well. Now, are those two equal? No. A lumpectomy is not as good as a mastectomy unless you add radiation. If you do a mastectomy, you remove the entire breast, so there's really nothing left, no tissue left to radiate. So you don't need radiation typically with that. But a lumpectomy leaves all the rest of the tissue. So is it potentially possible that a couple of malignant cells left the tumor and were on their way traveling down to the lymph nodes? You cut out the tumor, you took the lymph nodes are negative and the tumor's out, but a couple of stragglers were on their way to the lymphatic system, to the lymph nodes. Yeah, it's possible. So if you add radiation as a modality to a lumpectomy, then a mastectomy and a lumpectomy are identical. They are truly the same outcomes. And in fact, in a few cases, such as triple negative breast cancers, which are estrogen, progesterone, and HER2 new positive or negative cancers, some studies would point to radiation and lumpectomy actually being better. So again, it's all current data, but those two options are great if those are something that you need to consider. Then there's the whole idea of reconstruction. In my opinion, reconstruction is a wonderful thing, and Congress, thumbs up, did a wonderful thing, and they made it mandatory for insurance companies to pay for reconstruction for women who have had mastectomies. And I think that is one of the most wonderful things our government has ever done. Having said that, if you choose a mastectomy, you can get reconstruction. That can be immediate, meaning you can start that process the day you have your mastectomy with what we call skin expanders, right? And then once you've expanded the skin to the size that you want, you have the expander removed and put an implant in place, and then you can at least feel as if cosmetically you are like your old self. And then there's a question of can you do nipple sparing? Yes, that is a possibility. That's a conversation you should have with your surgeon before the surgery. They can do nipple tattoos, which I challenge all of you to go onto Google and type in nipple tattoo, and I guarantee if you take the quiz, you won't be able to tell which ones are real and which ones aren't. And then you can do nipple reconstruction, which is a plastic surgery thing, and those are all great options. So those are the basics of breast cancer surgery, you can start there. All right, last couple of questions. Oh, hi Pam, hi Lynette, hi Mags, and hi Jessica, my sister. Big family out pouring out here. This is fantastic for my primary and first one, which depending on how this goes could be my last one. I'm kidding. All right, another question is, where can I follow you? That's a great question. Thank you for asking. You can follow me on Facebook. I have a new Dr. Rad page, which is really awesome. My personal page really is just about my family and about my friends, not COVID. Having said that, Dr. Rad is really just about my medical journey, right? And it's for education, it's for purposes, and it's also just kind of about my own medical experience and kind of how I want to share it with people. You can also follow me on Instagram. They're both connected with the Dr. Rad. And of course there's a Twitter, but I really haven't figured that out yet, so I'll get to that at some point. Corolla. I had a sleeve in 2014 and I'm stuck. Can I have a bypass? Absolutely. Okay, there's a couple ways you can do that. One, you have regained some weight. In your case, you're stuck. But is your BMI still above 30 or 35? And do you still have medical problems? If that's the case, your insurance company will typically pay for your conversion, and that's a good thing. If you are stuck and your insurance company doesn't pay for it, then there are some other options from a medical standpoint. Medically, if you have a hiatal hernia, that is a possibility to convert you to a bypass. One of the things about a sleeve that's interesting, sleeves can typically make reflux worse or unchanged. Now, typically once you lose weight, the reflux goes away and it gets better, it's not a problem. Bypasses, on the other hand, have about a 92% cure rate for reflux, and it's an anatomical thing, and probably next show I'll have a whiteboard and we'll draw these things out and I'll explain it to you. If you had a sleeve and you have severe reflux, one of the things you can do, convert to a bypass, and you have a 92% chance of never having reflux again, which is wonderful, right? And then of course you can lose a few more pounds, and that's always an added benefit. So those are some of your options. Of course, depending on who your surgeon is and who you're talking to, you can self-pay to convert from a sleeve to a bypass, but you should only do that truly if you still have a higher BMI or you still have medical problems. And I think that's important, right? This is ultimately, it is for your health, right? I mean, this is for your health. If you have a weight loss surgery, a sleeve or a bypass, you have somewhere around a 75 to an 80% chance of never having a blood pressure problem again. You have a 90% chance of never taking a cholesterol pill again. You have a 90% chance of never wearing a sleep apnea mask again. I know they're attractive, but Darth Vader kind of went out in the late 70s, early 80s. Other problems, joint disease. People say, oh, Dr. Rad, if I lose weight and I have this surgery, is my joint pain going to get better? Are my hips going to get better? No. And I think that's an honest answer, and I just got to be honest. You can't fix bone on bone, right? You can't fix those issues. However, let's do some math. If you lost 100 pounds and you wear a Fitbit and you take just 2,000 steps in a day, that's it. I know people taking 10,000 plus steps in a day, right? But you just took 2,000 steps in a day. Well, every time you step on this knee, right? And then you step on this knee, that is 100 pounds on this knee and 100 pounds on this knee. And every single step is 100 pounds extra on your back and your hips. So just taking 2,000 steps in a day, do the math. What's 2,000 times 100? I'll tell you. If you line up something like 12 school buses in a parking lot, you are removing about that much weight or more from your hips, your knees, and your back every day. So yeah, will that help your joints? Absolutely. All right. And last question. Here we go. Ooh, let's get a good one. Once I lose, no, we already did that one. Is anemia common amongst your patients? Ooh, that's a good question. Okay, let's talk about anatomy for 2 seconds. If you do a sleeve gastrectomy, you didn't change the anatomy. All you did was remove about 80 or 85% of the stomach. But food travels the same path. So you should absorb all the food that you're eating, right? Well, true and not true, right? It's a misconception to think that you're fine. You didn't change my anatomy. What are you talking about? Why do I need to take these vitamins all the time? Okay, well, one, you can't eat the same amount of food that you used to. So you're not getting all the minerals and vitamins and stuff if you're eating small amounts of food that you used to. So yes, super important to take your vitamins, take your minerals, take all these things. Two, you removed 80-85% of the stomach. Well, a lot of that stomach was making gastric acid and stuff like that that was helping you break down food and get some of those minerals and vitamins and other things like that out of the food. Well, you're missing some of that. So yes, sleeves need to stay on their vitamins, their minerals, their calcium, and their iron. That's important. At the same time, it is unlikely that it is as important as a bypass. A bypass truly does mess with the anatomy a little bit. Now, is it dangerous? No. We've done this surgery for literally 70-something years. We've perfected it. All right, when we first started, a lot of people got hurt. 70 years ago, you had a 25% chance of not making it through the surgery. Things have changed immensely. We do all these surgeries laparoscopically through small holes, right? We don't bypass people nearly as far as we used to, but there is an element of malabsorption. Well, iron and calcium are mostly absorbed in that first part of the small bowel, right after the stomach. Well, if you do a bypass, you're bypassing that part of the bowel. So it is ultimately very important to take a multivitamin, iron, and calcium, especially with a bypass. You'll be fine if you take them. So to answer your question, is anemia a big concern after this? Well, of course. Iron deficiency anemia is one of the largest, I believe it's number 1 or number 2, right next to, by the way, low calcium and brittle bones for women, right? So calcium and iron are those two things that get malabsorbed in women already, let alone if they've had a bypass. And 78% of people who go to weight loss surgery are women. So super important to take your multivitamin, take your iron, and take your calcium, because if you don't, you can get anemic. Now, is it easy to combat? Typically, yes. You start taking more iron. There are iron infusions, there are all kinds of things you can do, but the trick is to get in front of it from the get-go. Don't get behind. So that is a great question. I think we're going to wrap up now. I have really enjoyed this, actually, probably more than I even thought I would. The Facebook modality, like I said, I was reluctant, but I think this is going to work out great. Please comment as much as you can. I need feedback. I need to know what you want to hear about. I need to know if I should do one of these again. Please follow me. If you think that this has been informative, share it. I know that sounds like an advertisement, and it might be, but share it. It's educational. It's fun. It's free. Send it. Send it to people. Have them text me personally if they want from the Facebook Messenger thing, and we'll answer every question we can get to. I just want to help, so it's a lot of fun. If I didn't get to your question, I will do my best to answer them in the comments section. And otherwise, God bless you, and have a wonderful night.